patient safety goals. And those of you who have working in an accredited hospital or who have interest in the patient safety as a subject would have heard this term. These are the international patient safety goals which were designed or which were developed by many people, but at present the Joint Commission International, that is JCI, as an organization is pushing for these goals to be adopted as wide as possible, and therefore the hospitals which opt for JCI accreditation have to compulsorily comply with these. So IPSG is one of the standards in the 7th edition of JCI accreditation standards for hospitals. So that is how they have incorporated or integrated the international patient safety goals in their accreditation program for the purpose of promoting patient safety in the hospitals. Similarly, the accreditation standards 5th edition of the NABH, the National Accreditation Board for Hospitals and Healthcare Providers in India, they also have incorporated, or they also have a requirement to adopt the international patient safety goals by the hospitals which are opting for NABH accreditation. And since the new edition of NABH accreditation, that is the 5th edition, will be applicable 1st January onwards, these will be required by the hospitals who opt for accreditation. In fact, it is also a very good idea for those hospitals who have not adopted the accreditation system but are improving they are working towards improving the quality of care that is being provided in their hospitals. So it's a good idea to adopt these goals because they draw your attention, they draw your focus to specific requirements as to what should be done in order to improve the patient safety. So the purpose, so we'll see these goals, and we will also see in some details as to how they are required to be implemented in the hospitals. So let us begin with this. There are 6 international patient safety goals. So the purpose of goals is to promote specific improvements in the patient safety, and these goals highlight problematic areas in healthcare and describe evidence and expert-based consensus solutions. So it is something which has a wide acceptance in the healthcare fraternity, in the fraternity that addresses the requirements of quality and patient safety in the hospitals. And I am very sure that all of us belong to that fraternity. So it is important for us to know how the international patient safety goals are helping us in many ways, and one of the ways that they draw our attention. And then when we learn more about it, we also figure out how these can be implemented. So the goals generally focus on system-wide solutions. So you cannot say that you have implemented a patient safety goal in the ICU or in some part of the hospital. These are system-wide and they are applicable to the entire hospitals. In that sense, I would say that these goals are, you can call them generic, which means they are applicable to all healthcare settings, wherever the patient care is happening, wherever there is an interaction between a healthcare provider and a patient, as well as interaction among the healthcare providers and also with the interactions with the family of the patients. So we will see for each of these goals. So there are 6 goals, and since the content is little bigger or more, so I have divided this into 3 sets of presentations in which I will cover 2 goals in each live session. Typically our live session is 30 to 40 minutes, and in order to do adequate justice to each of the patient safety goals, we should not do a shortcut. So therefore 2 goals per session, and so today's and 2 more sessions will be there on the international patient safety goals, though it may not be in this sequence, but they will all be covered. So these are the 6 goals. First goal is to identify the patient correctly. If you are aware of the patient safety literature and also aware of some of the groundbreaking work that was done in the late 90s, and also it is continuing to being done, the identification of patients in the healthcare settings and in all healthcare settings, OP, IP, ICUs, in the emergency departments, everywhere, wherever the patient interaction is happening and some activity is taking place, identification of patient is paramount, and the correct identification is the one that will save us from a lot of trouble that may arise from the problems of wrong identification. So this is the first international patient safety goal. The second patient safety goal is to improve effective communication. So we will cover these two today. And the other goals are improving the safety of high alert medications. These are also called the high risk medications in the NABH standards. So whether you call them high alert or high risk, these two terms can be used interchangeably. The fourth goal is to improve or ensure safe surgery. I'm sure all of us have heard of what is known as the surgical safety checklist. Now, this surgical safety checklist emanated from a World Health Organization, that is WHO supported program. And this program promotes the safe surgery. And one of the tool that they have recommended is the surgical safety checklist. So we will see this in the international patient safety goal number 4. The fifth goal is reducing the risk of healthcare associated infections. We all know how important the healthcare associated infections are, and typically in the hospitals we are addressing 4 primary, or rather 4 HAIs, which are the most important ones: the surgical site infection, the COTI, the CLABSI, and the ventilator associated pneumonias, that is VAP. But there are also many other healthcare associated infections that can happen. Those who are interested, for them, we will give the reference to those additional resources when we come to this international patient safety goal number 5. The IPSG 6 is reducing the risk of patient harm resulting from patient falls. Now, how important is patient fall in the hospital can be seen by the fact that preventing patient fall is one of the international patient safety goal. So from among all the patient safety issues that we may have seen in the hospital, or we may have experienced, or we may have heard about the patient safety issues that may happen in the hospital, these 6 are the most prominent ones. And if we address this, the expectation is that we would have addressed a large proportion of our patient safety problems and the subsequent consequences. So let us look at the goal number 1 and 2, and in the subsequent 2 more presentations, we will cover the other goals. So here is the first goal, and the first goal is to identify the correct, or identifying the patient correctly. So we need to know why it is necessary. So the wrong patient errors occur virtually in all aspects of care. Many times we are not aware of it. Many times we are able to detect these errors in time, so the harm is prevented. Many times the errors happen, but they get brushed aside. They may get brushed under the carpet. They are ignored, not discussed, or sometimes also actively hidden. So therefore, we need to be aware that patient identification is one issue that needs to be implemented absolutely correctly in the hospital. There can be nothing worse than administering a wrong medication, or carrying out a wrong procedure on carrying out a procedure on a wrong patient. This can become not only a serious patient safety violation, but it will also result in subsequent actions like the legal suits and claims and the consumer cases, etc. Now, we all know that a patient in the hospital may be sedated, the patient may be disoriented, the patient may not be fully alert, or the patient may be comatose. So, and also the patients may change beds, rooms, locations within the hospital. So patients will continuously, it's a dynamic system. Patients do move from one care setting to other care settings. So ICU to ward, within ward, sometimes the beds are changed for whatever reason it happens. But the patients change places all the time. Then patients may have sensory disabilities, so which means that the patients may not be able to, their cognitive faculties may be affected. They may not be able to hear or see or perceive their environment correctly. So that is another limitation we have. Patients may not remember their identity, and we all know that this can happen very it could be under the influence of medications, or there may be other issues involved. And patients may be subject to other situations that may lead to errors in the correct identification. So in this background, let us see what else is there. So the intent of this particular international patient safety goal is twofold. The first, to reliably identify the individual as the person for whom the service or a treatment is intended. So if you are holding a syringe in your hand and trying to look for a patient who's going to get it, so you must be very sure that this is the person who is for whom this particular medication or a procedure or injection or whatever is meant. The second is to match the service and treatment to that individual. So obviously, if we are going to carry out a procedure, that procedure has to be in accordance with the requirements of that particular individual. So these are the twofold intent of the International Patient Safety Goal number 1. So it is a best practice to involve the patient in the identification process to whatever extent possible. It is actually ideal to have the patient participating in the identification process. However, it may not be possible all the time. The patient may be under the influence of medications, or the patient may be unconscious or under an altered state of sensorium. So those situations are different. Barring that, the best practice is to involve the patient in the identification process. The safe care begins with proper patient identification, and this is by using at least 2 ways to identify a patient. So there are 2 identifiers, and we are, for example, patient's name, the ID, the UHID or the IPID, or whichever number the patient gets in the hospital as the process of, after the process of registration. The date of birth, or there may be a bar-coded wristband, or whatever else is the option available. So there is a requirement of having minimum 2 different ways to identify a patient. Patient's location cannot be used as the identifier. So when we have 2 identifiers, we can't have one of the identifiers or both the identifiers as the location of the patient. So we can't say room number, we can't say bed number, we can't say floor number, we can't say ICU, we can't say any location. So location is not the identifier. 2 patient identifiers used may be different in different circumstances or different areas. This is a matter of hospital's policy. So you may decide that the 2 identifiers will be same across all settings in the entire hospital, or you may say that for the OPD, these are the 2 identifiers. For the ICU, these are the 2 identifiers. In the OT, when the patient is under anesthesia, a 2 different set of identifiers will be used. But so you can have identifiers defined differently for different areas in the hospital. Labeling specimens, and this identification issue also pertains to labeling the patient. It pertains to specimens, it pertains to diagnostic test results, or for the patient's medical record. So it is not that only the person has to be identified, you also have to correctly identify the specimens, the test results, the patient's medical record, or whatever else that pertains to or that is specific to a particular individual patient. Name and an identification number may be used. So this is one option available. You can have many other options. The issue is, or the idea is, to have 2 identifiers. The 2 identifiers must, when they are used, they must be consistent within an area. So if you have only one set of 2 identifiers for the entire hospital, it is fine. But we all know that this one set will not work in all these settings in the hospital. So for a patient identifier in a pediatric setting where you have an infant or a toddler, obviously will be different from a patient identifier which is applicable for an adult who has today been admitted for an elective surgery. Because in the first instance, the patient infant will not be in a position to participate in the patient identification process. So we have to have a different identifiers for different settings. And however, when we say that in the operation theatre, this is the identifier. So for all the patients who are going through the process or any procedure in the operation theatre, that those identifiers will be used consistently. We can't have different identifiers for different patients, I mean, in the same setting. So we need to have some kind of a consistency in what we do. If the name and the ID number or a medical record number are used during the timeout, these are to be used for all timeouts. So this is an example that I have given. So if you are using, let us say, name and the date of birth for verbal interactions, for example, in the injection rooms or in the sample collection rooms or in the OPDs, so then in all such settings, you will continue to use only name and the date of birth. This is essentially to ensure that the staff which is involved in the patient identification does it correctly. The another example is that if you're using the name and the ID number or a medical record number in the operation theater, and you have said that during timeout this will be used. So for all the timeouts in all the procedure rooms across all the hospital, this will be consistently used. So that's the idea. Now, what are the special circumstances? So the special circumstances can be a comatose or a confused or a disoriented patient who has arrived with no identification, typically a person who has fallen or met with an accident on the roadside and is being brought by strangers or by the police people, maybe a newborn or infant or a toddler, and accident victims brought by strangers. So the process that will be defined will take into account the unique needs of these special circumstances. Sometimes you get an unconscious patient who's been brought by the passerbys or by the strangers from the roadside, and the patient is obviously requires admission and then a treatment in the hospital. Now, we have in our policy, if we have decided that we need to know the patient's name, then obviously this person will not be able to give you the name. And in that situation, we have to have a method that we have already pre-decided and trained our staff in as to how this person will be identified till the time we know the correct name or the actual name of the person. So the patients are required to be identified. So this is the problem which is included in the patient identification, that all the patients are required to be identified before providing treatments, and those treatments can be medications, transfusions, blood, IV fluids. It can also be something as mundane or something as innocuous looking as providing a restricted diet tray. So if you have a patient who is on a special diet, a renal diet or a hypertension diet, salt restricted, whatever, so even for this requirement, the identification is applicable. Performing procedures. So obviously, whenever we are inserting a line, carrying out whatever procedure, so we need to identify the patient priorly, and whenever we perform a diagnostic procedure. So how do we implement it in the hospitals? So we make a policy, we write a policy or a standard operating procedure as SOP, or as it is commonly understood by everyone in the hospitals. So we design 2 patient identifiers which will be excluding, which will not include location of the patient. And these will basically help us in identifying the patient and to label the elements associated with patient's care or the treatment plan. So these elements can be the specimens, the records, the reports, case sheets, case files, investigation requisitions, referrals. So whatever else is used, so this will be the method. The patients are identified before performing diagnostic procedures, treatments, or performing any other procedure. Ensure correct identification in the special circumstances. And these are the SOPs that we are required to write in order to implement this particular standard. Now, if you are implementing or if you have implemented a quality system in the hospital, for example, NABH or JCI or NQAS, any which, or maybe you have not gone for accreditation, but you are implementing systems in the hospital, then when you are defining how the patients will be identified, these are the requirements. So you must say that the patient identification will be done like this. So 2 identifiers, then define special circumstances, define different areas where two different sets of two identifiers will be used, and also include the requirements of unconscious patients, those under anesthesia, under the altered state of sensorium, minors, infants, toddlers. So these special requirements must be included. So I have finished the international patient safety goal number 1. If there are any questions, that will be great. Anyone? Let me see the chat box.
Sir, in case of a newborn, can we consider their ID band? So, like in ID band, we generally stick our name tag, like patient's name, MPI, and everything. So, can we consider for a newborn that will be a
Yes.
when we are tallying it?
Yes. Yes. So, if you have handed over the newborn to the mother, the problems will be less. Okay. But yes, you have to have a ID band, which cannot be removed, and it is tagged either on the wrist, or sometimes it is also tagged to the ankle. I've seen in some of the hospitals. Yes, and a lot of hospitals, I think it is all more or less a widespread practice that you take the footprint of the newborn. Is it happening in your hospital? After the
Yes, sir.
So you have now two methods available: a print and footprint, and the ID band. So similarly, you can decide. The freedom is to you. So long you do not use a location of the patient, it is fine.
Okay, sir.
Doctor,
Thank you, sir.
You're welcome. Dr. Ashok Sharma has asked, can patient's photo be used for identification? Yes, you can, but how will you put photo in every document of the patient, on all the forms, investigation reports, etc.? So photo can be used, there is no doubt about it, but it has the logistic problems. How do you put photo everywhere? Shrita Raj has said, sometimes they will be with same patient name and date of birth. Yes. So therefore, when this is possible, or when you suspect that this might be the reason, please also look at the UHID number. And like Dr. Ashok has suggested, maybe a photo. I mean, finally, how we identify the patient is up to us. Us means the healthcare providers. The requirement is to always identify the patient correctly. Okay.
Sir, may I ask a question, sir?
Yes, please.
Sir, if a bus is running on a highway and it falls in the river, and it has 50 patients, and all the patients, all the persons die on the spot, and the bus is brought to the hospital with 50 patients all dead. The attendants of the patient reach the hospital after 2 days or 5 days because they are from different states.
Yes.
How do you identify such patients? A mark of identification of such patients.
Okay. What is your name, if I can, because I can't see on my screen? What is your name?
Sir, my name is Dr. Jaswant Arneja.
Okay, so Dr. Arneja, I think we have also spoken a couple of times earlier. Now, in a situation where a patient is brought dead, or he dies on when dead on arrival, or dies death on arrival. So in this situation, you have no idea who this person is. So in such a situation, how do we identify? What would be the best way to do it? Jyoti ji has also asked the same question. So what if the patient is unconscious, or the patient is dead, or the person is dead? How do we identify such a person?
Sir, we name them as patient 1, 2, then we mention their identification marks, and sir, we can click some photos and
Correct.
We can provide it.
Yes, absolutely. You are on the dot. So you have in many hospitals, when they design a disaster management program which deals with such situations, what Dr. Arneja has just described, that you have a tragedy somewhere and a lot of dead bodies are brought to the hospital. Now, in such a situation, you will have to have a method to identify the persons, or the bodies. Fingerprint is one option. Clicking photograph is another option. Recording identification marks is one more option. In fact, in the disaster management processes, a lot of hospitals have a method where the photograph of each casualty which is brought to the hospital is clicked, and then it is because at that time you may not have the time or the resources or the wherewithal to really do an identification of the patient. So the fastest method is possibly that you label the patient as patient number 1 and then click a photo, and thereafter you keep doing whatever else treatment is required, and subsequently we can set the whole thing right, that you collect information, or as the more information is available, it can be done. So yes, these are the methods, Dr. Jaswant, that you could take fingerprints, you can take the photographs, you can record the identification marks, for example, the scar marks, or I mean, like we do for any other person who's to be identified. Police people are generally pretty good at this, so they also help. Okay, I think Dr. Rama Mohan, your question is also answered for unconscious
Sir,
patients. I'm
can
going
I
through
ask
the
you a
chat
question?
box.
Sir,
Yes, please.
can QR code be a identification point?
Yes, madam. So then for having a QR code or a barcode as an identification, your hospital will have to have a system to generate these QR codes for each person or a body that is brought. That is number one. Secondly, you will need to then have a system as to what information you will record for that particular barcode. I mean, it is just like giving patient number 1, giving it a number. So you are, instead of a number, you are giving a barcode. But behind barcode, whatever is the information you are capturing, you will still have to capture the fingerprints or the photographs or the identification marks, and those identification marks, pictures, photo will then be linked with this QR code. So QR code is a method of coding, but basic information you will still have to capture. I hope that answers your question. General Bhutia
Thank you,
ma'am,
sir.
thank you for joining this program, and it is nice that you found it informative. We do this every Saturday. Okay, Jyoti ji, I think your question is also answered about the unconscious patient found on the street and brought to the hospital. Dr. Ashok Sharma, in case of obstetric ward, ID of the mother is essential with the ID of the newborn. Yes, you can tag these two. It's a good idea, because then you will know exactly that these two are linked even in your hospital systems. So it can be done. Suresh V has said different colors of band are used in the hospital. We suggest how to choose the color band for the patients. Is there any specific color? Suresh ji, there is no such specific color. You decide. I mean, you are the boss. You decide what color code you want to give it to someone else. Okay, so it seems the questions on this topic, you can ask more questions subsequently also, and if you remember something in between. So let us go to the international patient safety goal number 2. And this is about the effective communication. So please, you will need to distinguish between what is communication and what is effective communication. So let's see what it is. The intent of the communication, or the intent of the international patient safety goal is, so in a couple of slides we will cover that. The effective communication results in improved patient safety, and the effective communication is characterized by, it is timely, it is accurate, it is complete, it is unambiguous and understood by the recipient, and it reduces errors. So when you say that this particular communication is effective, then it has to have all these attributes: timely, accurate, complete, unambiguous, and understood by recipient, and it reduces errors. So communication can be electronic, verbal, or written. It can be over telephone, over voice over IP, internet call, WhatsApp, whatever else. So all that is included in the communication. Communication is also what is handed over from one nurse to another at the time of shift change. It is also when a patient is handed over from the ward to the OT, or ward to the ICU, or ICU to ward, etc. So we'll see how it works. So patient care circumstances that can be critically affected by poor communication are verbal and telephonic patient care orders, verbal and telephonic communication of critical test results, and handover communications. So these are particularly in focus, other than, of course, the entire communication is in focus, but these are the areas where the patient care circumstances can be critically affected by poor communication. So we need to know, and we need to be very careful when we are communicating for these requirements or these situations. Verbal and telephonic patient care orders, verbal and telephonic communication of critical care, critical test results, and the handover communications. Okay. So the verbal patient care orders are the most error-prone communications, and there are studies to document this, studies that have documented it. So these are the most error-prone communications. The different accents, dialects, pronunciations can make it difficult to understand an order. For example, the drug names or numbers that sound alike, so erythromycin, azithromycin, 50, 15, and communication is so important, especially when a verbal communication is taking place in relation to a patient care requirement, that we all need to be very, very conscious during these times. Background noise, interruptions, and unfamiliar drug names and terminologies further compound the problem. So not only we have a problem uh, because of dialects and accents and pronunciation requirements or the limitations of people, we also have other issues that will compound the problem. Transcribing requirement adds another layer of complexity. So for example, you are working in the hospital and you are in the ward, and a telephone call comes from the lab, and the lab is trying to tell you a critical result. Now, this is a combination of a telephonic conversation, which is verbal, and you are at the same time trying to record. So if you do not hear it correctly, you will not record it correctly. And what gets recorded will subsequently be used for patient care requirements. And obviously, there can be major issues in this. Okay, so the critical results of diagnostic tests. So a critical result indicates a high risk or a life-threatening condition, which is urgent or emergent, and in which immediate medical action is likely to be necessary. It may not be necessary, but it is very likely and highly likely that there will be a requirement of immediate action. This is different from an abnormal result. So this is basically to distinguish between what is abnormal and what is critical. So let us take an example of blood sugar, and you have carried out a random blood sugar test for a patient who's in your ward. Now, a sugar level of maybe, let us say 90 is, you may say that it is low, but it is not life threatening. You may say it is abnormal, but this is definitely not life threatening. But if you measure a sugar level of 40 or 30 or maybe 25, then definitely some action is required to be taken immediately. So this becomes a critical result. So this is to distinguish between what is critical and what is abnormal. It may occur in outpatient, it may occur in inpatient, it may occur in patient care areas and wards. And it may be produced from any diagnostic tests performed at the bedside. So sometimes the lab is very well aware of the critical care requirements, but the tests which are done at the bedside. So we have a lot of point of care testing, glucometer testing of sugar, the ABG machine being used for testing. We have portable imaging, which is done on the bedside, the portable X-ray machine. We may have ultrasounds being done on the bedside. We may have ECG, or in fact, ECG is almost always done on the bedside. So these are the tests which will also produce critical results. So when you are making a policy for communication of critical results in your hospital, then you must remember that bedside testing or point of care testing is also required to be included there. Now, these critical results are different from continuous electronic monitoring. So in the ICUs, we have a lot of patients who are on continuous monitoring. Now, this is different from continuous monitoring. A continuous electronic monitoring is a clinical assessment tool used to detect changes in the patient's condition that may identify a threat to life. But it is not designed to produce a defined critical results. So this is a matter of little nuance, that the critical result is different from, let us say, a finding of ECG or a finding of an abnormality that you see on the monitor, which is different. A formal reporting system to provide results within a defined time frame is to be used throughout the hospital that determines the method of communication of critical results to medical professionals and the documentation of this communication. A lot of hospitals have their SMS system or the WhatsApp integrated in their processes, and that is where when you send a result, that result obviously is not likely to be corrupted by the communication channel itself or by any other means. So when you write something on such means, then the information which is communicated is likely to be most accurate, unless someone has typed wrong. So then we need a different level of verification there. The next variety of communication is the handover communication, and these happen between the care professionals. So doctor to doctor handover during shifts in the ICUs, in the OTs, in the wards, doctor to nurse handover, nurse to nurse handover, a physiotherapist to another person handover. So like that, this kind of care, the handovers keep happening in the hospital all the time. Between different levels of care, so ICU to OT, OT to ward, ward to ICU, between wards, ICU to lab, imaging, physiotherapy, etc., and between staff and patients and families, such as at the time of discharge. So this last point is usually forgotten. So that is why I have specifically and separately mentioned it. So there is also a handover communication that is happening when the patient is going out of the hospital, he is going home. You are explaining to the patient what all medications, what all precautions, what kind of diet, what kind of lifestyle the patient should be leading now onwards, and that is also a kind of handover communication. So breakdown in communication can occur during handover. Interruptions, distractions inhibit clear communication of patient information. And our mobile phone is the biggest culprit in creating interruption. So a lot of people, as a good practice, they don't attend their phones when they are seeing patients or when they are in the OPD or wherever. Of course, the kind of work you are doing, it may actually require that you have the phone with you all the time. Standardized forms, tools, methods enable a consistent and complete handover process. We cannot, we don't have the opportunity to get into how to design a form, but we'll mention how it is done. A process may be different for different type of handovers within the hospital. So emergency to ward handover process may be different, and OT to ICU handover may be different. So this needs to be figured out. Handover forms or tools need not be part of the medical record. So this is another point. A lot of times when I'm visiting hospitals or when I'm doing consulting or when I'm conducting sessions like this, the questions are asked whether handover form, you have shift handover forms, whether these forms or the registers are part of patient record. So they need not be part of patient record. It's up to you. You can decide whether this should be included in the patient's file. But the hospital may want to have documentation that the handover has occurred. So this is the requirement, that the hospital must have a record that a handover has been correctly done. Why? Because if there is a sentinel event, there is an adverse event, that is the time when you would want to investigate why that sentinel event has happened. So at the time of doing the root cause analysis, you will need this information of handovers. So you may like to have this in your hospital records, but they may not be part of the patient's record. Care professionals record that he completed the handover and to whom the responsibility has been transferred, and then this particular record is dated, signed, and the time of entry is recorded. So this is the minimum requirement. What are the safe, effective communication practices? Limiting verbal communication to urgent situations in which immediate written or electronic communication is not feasible. For example, during a sterile procedure. So if you're in the middle of a procedure, obviously all communication might be verbal. Implementing guidelines for requesting or receiving test results on an emergency or a stat basis. But you must implement some method where how this will be done. So identify the test, know the critical values, to whom and by whom the results have been reported, and this reporting should be recorded in some manner so that the compliance can be monitored subsequently or can be evaluated subsequently. Okay. Writing down or entering into a computer the complete order or a test result by the receiver of the information. The receiver reads back the order or the test result to the person who is telling this result. The sender confirming that what has been written down and read back is accurate. Permissible alternatives when the readback is not possible may be identified, such as in the operation theatre or in the emergency situations in the emergency department or in the ICUs. So where reading back is not possible, then some alternative must be there. Either you assign an additional person or in some manner ensure that the communication is correct. And using standardized content of communication during handovers. So this essentially means that you have the formats for handover. Using the standardized methods, forms, or tools to facilitate consistent and complete handovers. Complete verbal and telephonic orders and test results are documented and read back by the receiver, confirmed by the person giving the order or reading the result. Defining the critical results in the lab. This is important. Of course, this is also part of another set of standards, both in JCI and the NABH. But since we are talking about the effective communication, so we are mentioning it here. Implementing a formal reporting process used throughout the hospital for reporting or communication of critical results. Identifying when the information is, identify what information is recorded in the medical record. So during the handovers or during this communication process, we should have identified in our procedures, in our standard operating procedures, what information will compulsorily be recorded in the record. Standardize the critical content during handover, because once you standardize, this can be converted into a format, and once it is a format, then the chances of error are less, because nobody will have to remember what all to write. The format will say, okay, fill this information, and that completes the set. Standardized forms, yes, they support the complete handover. Data from adverse events resulting from handover communication should be tracked, and that is the reason why we need to record it, and used to identify ways in which the handovers can be improved. So for example, you have implemented a system of handovers in the hospital, and your handover format has a certain set of information that is recorded. But when you are investigating an adverse event or a sentinel event, then you have found that this additional information should also be recorded in the handover, so that the handover is better and the sentinel event can be prevented. So in that situation, this additional information should also be incorporated in the form. Okay, so we have completed. The last slide is what are the standard operating procedures that we need to implement. So we need to have a process for verbal communication, process for telephonic communication, process for critical test and results, process for handovers, and defined and standardized forms and tools for communications and handovers. A lot of them are available on the internet. In fact, a lot of hospitals procedures are also available nowadays on the internet. The idea is not to copy any of that blindly. Please take help. There is nothing wrong in that. Please see what you are implementing and see what your system is. So as per the requirement of your hospital, modify that content. Take everybody into confidence, all the people who are supposed to use those formats, give them training, and then have a monitoring system so that your forms are correctly filled and implemented. So I have finished. There are a few questions in the chat box. I will take that, and then I also request you, anyone who has a question can ask. So Dr. Madhurika Jain wants a presentation. Yes, it will come to you. Sahitya Imidi Sethi also wants a presentation. So all those who want a presentation, please put your email ID. It can be sent to you. There is no problem, and we have no issues with sharing the presentation. It can be done. Revati ji has asked how doctor-to-doctor handover can be done. Suggest some ideas. Oh, doctor-to-doctor handover is essentially in the form. I mean, we have discussed that. So I think at least as I understand, I have given this answer. But if you want to ask something specific, please say that, madam. Gina Raj is asking, is it mandatory for doctors to hand over in wards too? Madam, you have to see your hospital setting. There is no prescription. But typically, wherever there are people in shift duties, when the shift changes, they are supposed to hand over. So if your ward is like that, it is required there also. So the presentation is required by a lot of people. Yes, it can be sent. Okay, so there are no more questions. Is there any other question that someone wants to ask? We have completed today's topic.
Sir, how can we tell doctors to give a handover? As there is a mandatory quality indicator in NABH as well as JCI.
Yes.
Like, what should we tell them? Because nowadays the doctors started writing the prescription in capital because that is mandatory, and then they don't want to rework on the same.
So you don't have to see,
Yeah,
madam. You don't have to write the entire prescription all over again. I mean, you will really need to work out, sit with your doctors and see what can be the easiest way to design your handover form or design a handover so that you meet the requirement, at the same time don't increase anybody's work. This is the commonest misperception, if I can call it, is that the quality system requires a lot of documentation. I am afraid it is not so. It is not that we need to generate a lot of forms and we need to generate such complicated documents that nobody wants to do it. No, it is not. It need not be like that. But yes, there are specific requirements of the quality system, and those requirements have to be met. So we have discussed the requirements. Now you can see, madam, how it suits you and how to make it simpler. So you may have a system of writing prescription where the prescription can be written just once and there is no need for them to copy it again and again, because every copying will also create errors. Please remember, the number of times you transcribe a particular information, that also will create errors. So that is not a good idea. So you'll have to really see how it works. I mean, I can't give you a specific solution that pertains to your setting, but it can be simplified. This much I definitely can tell you.
sir, may I add?
Thank you,
We
sir.
have that ISBAR communication tool, which can be
Yes,
utilized for handover takeover from doctors
yes.
to doctors and doctors to nurse also.
So
That tool
lot
is
of
really very
yes, I agree. The SBAR tool is very, very good. The nurses are, in most instances, very comfortable using it. The problem is getting doctors to use it. It requires a bit of motivation, but that's a very good method of handover, and you will not miss. It's designed for a good quality handover. So the SBAR tool can be used, as suggested. Dr. Rupashri said, yes. Pallavi, madam, I hope you have heard it. So SBAR tool can be used. It's very good, easy to use, acceptable to all the accreditation systems, and also makes life easy for everyone.
Yes, sir. Thank you, sir.
Okay, any questions? Anyone else? So we have finished today's topic. If there are no more questions, then we can close the session for today.